ETSU. My name is Gerben Sidhu. I'm part of the resident team here at ETSU. I have the pleasure of introducing Dr. Jill Stinson today. She is a psychologist certified in Tennessee and currently teaching in the Department of Psychology at ETSU. She is also the director of the sex offender program here, and she's done her doctorate at Fulton State Hospital in Fulton, Missouri, where she was also the director of sex offender program there. Excuse me, I misspoke earlier. She's the associate editor of sexual abuse program here. And then she also did her PhD at the University of Arizona. Actually, she did a joint degree in psychology and policy and law. And she has 3 publications under her belt in the field of sex offenders and motivational interviewing with offenders. So please give a big round of applause for Dr. Jill Stinson.
Thank you. Thank you for having me here today. And so I have just to disclose, no personal or professional financial relationships. In other words, I'm not benefiting off of giving a talk about suicide, just to be clear. A little bit about me here at ETSU. I'm an associate professor in the Department of Psychology. I'm also the director of clinical training for their clinical psychology PhD program. I've been here at ETSU. This is my 7th year. And as mentioned during the introduction, prior to that, I spent 7 years at Fulton State Hospital, where I was the director of sex offender treatment. And that is a 500-bed maximum and intermediate security inpatient forensic psychiatric hospital. So I've got a lot of experience working with sex offenders, a lot of publications specific to sex offenders with serious mental illness, sex offenders and suicidality and self-harm, and also just in general kind of violent offenders in the forensic mental health system. So the questions I get most often are, 1, why sex offenders? Usually followed by, does your family know you do this? They do. Why forensic mental health patients and why suicide? I don't have a really good answer to any of those questions. I don't have a really entertaining answer. It's just I'm interested in these populations. They're fairly underrepresented. People don't often say, when I grow up, I want to work with sex offenders who are suicidal. That's not a common answer. So I gravitated toward this area because I felt like it was a really fascinating but underserved and highly stigmatized population. And so while most of my work and publications previously have been specific to sex offenders and suicide, today I'm going to broaden that out a little bit and in general talk about offenders and suicide and self-harm. All right, before I continue, can you guys hear me over there? Okay, good. All right, so recently, and by recently I mean just a couple of weeks ago, in the news, we've been seeing a lot more about offender suicide. So in France, in September and October, 2 priests committed suicide or died by suicide after being accused of inappropriate sexual behavior. Their victims were ranging in age. For one of them, they were predominantly young children, and at least one of them was accused of sexually assaulting and molesting an adult woman. It's unclear as to whether or not she was under any kind of voluntary guardianship or care. Both died by suicide prior to formal charges or trial, but after being questioned repeatedly by police, and there was belief that there was sufficient evidence that they probably would have been taken to trial. Also, many of you, if you watched Glee, you'll know who this is. You may have already heard this. Mark Salling in January of 2018 died by suicide following pleading guilty for possession of 50,000 images of child pornography. And he died prior to his sentencing. There was about a 6-month gap between his plea bargain and his sentencing date. And he was expected to receive 4 to 7 years in prison. All 3 of these individuals died by hanging or ligature. And you may have heard of other cases in the news. These are sex offenders. This is weird. I get Google alerts when sex offenders and suicide come up in the news because this is an area that I study. But also we can think of other ones like Aaron Hernandez, who was the tight end for the New England Patriots, who died this past April in 2017. He also hung himself in his cell and had been convicted on 2 counts of murder and had his convictions overturned and was awaiting retrial. So I bring these up because this is not something that's different or uncommon, sadly. When we talk about these concepts, just some brief definitions. We have death by suicide. That one's pretty straightforward. However, there's a lot of ambiguity in the literature, particularly with regards to offenders who die by suicide by means of overdose, because it's unclear, did they intentionally overdose or was it unintentional? We have suicide attempts, suicidal ideation, or the thoughts about wanting to commit suicide or die by suicide, and then self-harm behavior, which is also called non-suicidal self-injury. I usually use the term self-harm behavior. Conservatively, in a lot of the offender literature in particular, they will take things that they aren't sure if it's a suicide attempt and lump it under self-harm because they don't know if the person's intention was to die. So you see kind of a split in the literature in terms of how they address these issues. Now, who we're talking about when we talk about offenders, there's largely three different groups. The first group is custodial offenders. These are offenders who are in jail or in prison or detained in some form. So they are in secure care. We're also talking about community offenders, and that's a wide range of people. That can include people who are under pretrial investigation and questioning. That can include people who are on probation or parole in the community. It can include other post-release offenders as well. So the literature is very diverse in this area and very mixed with regards to which groups they're talking about. We also have the offenders that I've worked with most often, and those are the offenders in the forensic mental health system. So these are the ones who may have been found not guilty by reason of insanity, or who may have been involuntarily civilly committed under a number of different statutes related to an offense and this assumption of dangerousness, and they're also being held in secure care, but within the mental health system. However, in working with these offenders, what you see is very similar in many ways to what you see with custodial offenders in prisons and jails. Okay, so prevalence. How often does this happen? Well, in terms of U.S. jails and prisons combined, in a 3-year catchment study, they found that 23 per 100,000 prisoners died by suicide, which represented a total of 2,143 deaths during that time frame. Jail rates, because this is an aggregated number, jail rates are 9 times higher than the rates of people who die in prison due to suicide. That's at a rate of 43 per 100,000. Jail populations are far more risky and transitory. If you think about some of the characteristics related to them, they don't necessarily have their legal charges resolved yet. So jails include people who have been sentenced to a period of less than a year for incarceration, and also people who are awaiting trial. And so they are a very high-risk group. It also includes people who've been arrested but who haven't even formally really seen a judge or entered the system yet. And so sometimes people after arrest within those first few days may be at very high risk. So jails are far riskier places in terms of offenders dying by suicide. Suicide is the leading single cause of death in U.S. jails in 2014, representing 35% of all deaths. And the third leading cause of death in state and federal prisons. Now, these populations are there longer term, they're less transitory, and so the leading causes of death in state and federal prisons are heart-related diseases, hypertension, heart attacks, that kind of thing. And then HIV is very rapidly rising as the second cause of death. Now, in terms of suicidal ideation and suicide attempts, it's 3 times higher in correctional populations or custodial offender populations than it is in the general public in the U.S. And it ranges, depending on which groups you're looking at, from anywhere of 10 to 25% of offenders. So it's a pretty significant number of people. And this isn't representative, just thinking of the number of attempts that some of these folks may make as well. Now, self-harm behaviors or self-injurious behaviors that are not predicated on an intent to die are not consistently tracked in U.S. prisons. They don't often report on self-harm. They report on deaths in custody. There are research studies that look at the prevalence of self-harm in a given prison or a given population, but we don't have national statistics. We do have national statistics from several other countries, though, to give us a sense of some of the scope. In Ireland, 4% of prisoners in a given year engage in self-harm behavior, and it's more than 4 times higher among female prisoners. That tends to be true across all locations with regard to self-harm, that female prisoners are at higher risk of self-harm behavior than are male prisoners. In Canada, we see that 14% of female offenders are responsible for 79% of self-harm incidents. So for people who are working with incarcerated women, this is a significant area of safety concern and institutional planning. So how do we compare internationally? We see these numbers and, we're saying it's a lot higher in incarcerated populations and in offender populations than it is in general population that does not include offenders. Then how do we compare internationally? Well, this is where we should, I guess, be proud of ourselves. But at the same time, the scope of death by suicide in prisons worldwide is fairly significant. And so Norway has the leading rate of first world countries, and some countries don't report their rates, so we don't always know, but in terms of those that do, Norway has 180 deaths per 100,000 prisoners, and compared to ours, which is 23. So we're doing something right, maybe, but the sad question is, what are we doing that's so helpful? And most researchers say, don't really know. We do know risk factors, and we'll go into that, but we do know that in the US and Canada, we see rates of death by suicide in custody at far lower rates. Now, looking at prevalence, it really varies according to the point of contact and location of the offender. As I've already mentioned, really risky times are after arrest and pretrial, before things have necessarily been settled. And the belief is that among people who know that they're responsible for the behavior that they've been arrested for, and that carries a great degree of stigma, that they are probably the highest risk group of dying by suicide after arrest. We also have the custodial folks, the jails, state prisons, and federal prisons, and again, there's variability there. Post-release, these are the folks who've been incarcerated and who then have been released into the community, and they look very different with regard to kind of risk factors and characteristics than people who are in custody. And then also folks on community supervision, who are generally seen as people who are lower risk for violence and recidivism, but who may still have fairly substantially high rates of suicidality. The literature also shows us, though, that this does vary pretty significantly by offender type. And so in some of my research, for example, I found that simply being a sex offender puts you at greater risk of making a suicide attempt. And so sexual offenders and violent offenders are at greater risk than non-violent, non-sexual offenders. In comparison, again, with general population, I mentioned that 23 per 100,000. The death by suicide rate in the United States during that comparable 3-year period was 1.3 per 100,000. So I think I did the math on that. It's a magnitude of 18 times greater if you are an incarcerated offender. And in self-harm, it's 3 times higher in offender populations than non-offenders. So still, we're looking at some fairly significant scope of problematic behavior. Now, why is it so much higher in offenders? Well, there's a lot of overlap with existing risk factors for suicide. So some of the risk factors for suicide just generally are things like a prior history of suicide attempts, a history of mental illness and psychiatric hospitalization, history of depression, and impulsivity, early experiences with trauma. And what we see among offenders is that they have disproportionate exposure to this risk. So offender populations are far more likely to have a history of adverse life experiences in childhood and early adulthood, higher rates of maltreatment, trauma, dysfunctional and chaotic homes, a greater problem with impulsivity. I mean, they're offenders. If you've ever worked with offenders, they're an impulsive group as a whole. Offenders have higher rates of mental illness than non-offenders do, regardless of custodial status. A lot of times people will say, oh, well, they're in prison, of course they're depressed. But many of them had recognizable symptoms of mental illness even prior to having been detected as an offender. And so we also have to look, though, too, at not only do they have these existing risk factors that are higher for them, but there are features unique to corrections in the criminal justice system that may exacerbate the problem. So one of these is increased stigma. And if you think about that in the context of what I stated about simply being a sex offender is a risk factor for people attempting suicide, thinking about suicide, self-harming, we tend to not like sex offenders very much in our society, and so they know that very, very well. And in fact, they will often verbalize that they know everybody thinks that they would be better off dead. And they see the news and they read about this, and so they know. We also see in offender populations a far more limited access to resources than is the case in non-offenders. In terms of mental health access in U.S. state prisons, the going number is about one mental health professional per 1,500 inmates. And so if you think about the fact that about 2/3 to 75% of inmates in U.S. prisons have at least one diagnosable psychiatric disorder, 1 per 1,500 probably isn't going to cut it in terms of getting them sufficient medication access, sufficient psychotherapy access, or even just assessment and screening. And then there are a number of systemic factors, and we'll kind of go into some of those, but have any of you ever worked in, toured, I'm not going to ask if you've been in one, but how many of you have some familiarity with a jail or prison? You've been in it, toured it. Are they happy, fun places? No, right? And generally, the staff, I've worked in state prisons as well as psychiatric hospitals, and one of the first things they tell you is this litany of ways that people will try to manipulate you and con you. And so there's this expectation going in that you can't believe what people will say. And I think as a mental health professional, that sends kind of this mixed message, because if you have somebody who is endorsing a lot of suicidality, there's always that person standing to the side going, oh, they're probably just trying to get a cell to themselves. Well, what if they're not? Right? What if that isn't a cry for help or cry for attention, as I've heard so often? I'm like, they almost died. So we shouldn't discount that. But systemically, we tend to view offenders with this very skeptical lens. Now, in terms of risk factors, I'm going to divide them here into several groups. The largest group, because we have the most research on this and the most consistent research, are these historical and individual factors. So, as is the case with non-offenders, previous suicide attempts and or self-harm behaviors are a very strong predictor of continued suicide attempts, suicidal ideation, self-harm, and even death by suicide. Previous psychiatric hospitalizations. Also, it's higher in this population. The base rate of people endorsing a prior psychiatric hospitalization is higher among offenders than it is in the general population, but it still stands as a pretty strong risk factor. We also see some of these other ones, diagnoses of depression, post-traumatic stress disorder, other sort of trauma-related disorders, psychotic spectrum disorders, and some personality disorders. Now, the psychotic spectrum disorders, they often get overlooked in suicidality research, particularly with regard to offenders. But they are actually a very strong risk predictor among offender populations of suicidal behaviors. Personality disorders, probably not surprisingly, the highest one's going to be borderline personality disorder. But antisocial personality disorder is also a really controversial one, because that one often, they kind of push that one to the side and say, well, they were trying to get medication or they were trying to get moved to a different place. From a risk management perspective, and having been a hospital administrator, I can tell you I'm not really concerned sometimes why they did it. It's the fact that you still have to protect them from seriously hurting themselves. But the other thing is, a lot of folks with antisocial personality disorder have a high degree of impulsivity and affective lability, and those things lend themselves to suicidality and self-harm as well. Now, family history of suicide is a really prominent factor here among offenders, and that's true for non-offenders as well. But if you look at offender populations, you have higher endorsement of family history of suicide or family history of really questionable deaths, where they're not sure, right? A parent may have overdosed, but that parent had also made numerous suicide attempts in the past. And so there's some degree of normality for them to have someone close to them in their lives who's suicidal. Substance abuse is a risk factor, and it's different for community versus custodial offenders. Custodial offenders, the substance abuse does still kind of come up as a significant risk factor, but it's not, the magnitude of it isn't as great as if they're in the community, either post-release or on some kind of community supervision. And that's still largely because when you look at the greater suicide literature and they discuss the lowering of inhibitions that's related to alcohol use, for example, that can precipitate suicidal behavior. We've talked a bit about impulsivity. Hostility is another one that's interesting because your more hostile inmates or hostile prisoners are not the ones that people generally want to spend a lot of time screening, and they are more difficult to engage in screening for suicide risk because they don't want to spend a lot of time with you or don't want to tell you about their personal innermost thoughts. But these individuals actually are at higher risk, and they often go less detected than less hostile inmates. Also, that history of childhood trauma and maltreatment, limited social support, which kind of ties into stigma and has an interaction effect with gender. Having worked in a variety of settings with both male and female offenders, I can tell you that the male offenders are more likely to have significant others come visit them than are the female offenders. Female offenders may have parents come visit them or sometimes someone who's bringing their children to see them, but very, very rarely have they ever had a significant other, spouse, anyone visit them, whereas with men I see that far more commonly. So the social support dynamic is different, especially if you think about women who are offenders have these higher rates of childhood trauma and maltreatment, and so if their parents are the ones coming to visit them and their parents are the ones who did this, we can guess that that's probably not the best, most socially supportive relationship. So it may actually not count as much in some regard. In terms of gender, it does depend. It depends on which behavior you're looking at. Male offenders are more likely to die by suicide. That's also true in the community of non-offenders, that women make more suicide attempts, but more men will die from suicide, and it's usually because of the lethality of their means. However, when you look at offender populations, the rates of self-harm, as we've discussed, it's a far greater risk for women than it is for men. And then in terms of age, as an individual risk factor, there's two age ranges at which offenders are at highest risk. One of these is when they're fairly young. And so there's a whole literature on juveniles within juvenile correctional facilities and their risk of suicide and suicide attempts and self-harm, and then also young offenders pretty much before the age of 25, 26. But then there's increasing literature showing that older offenders are at significant risk as well. And that kind of maps on to what we know about suicide risk in non-offending populations, that elderly persons are increasingly making suicide attempts and dying by suicide, and that is also the case of elderly offenders, many of whom have been incarcerated for quite some time. Now, when we look at situational risk factors, this is where situational and systemic risk factors, this is where we don't have quite as much research. And when we get to systemic, you'll see why. But in terms of situational factors, the length of sentence or length of incarceration does matter. And it interacts with the recency of incarceration. So if someone receives a very, very lengthy sentence in a facility, they are at greater risk of suicide. Why do you think that is?
They're probably going to die in prison anyway.
Right. They think, I'm going to be here forever. Prison's not a fun environment. I don't want to be here that long. There's also some evidence suggesting that there's a control aspect of I will control how I die in prison. Okay. That also interacts with that recency effect. They're at greater risk right after they've been incarcerated. So within the first month or two up to the first year. After that, there seems to be something that happens where they adjust to it For better or worse, they adjust to incarceration, and then their risk goes down. But that length of sentence interacting with how soon, how long they've been there is important. Offense type, violent and sexual offenders are at greater risk. And interestingly, victim type has an effect. If you think about it, though, it doesn't work quite the same way that we would expect. It depends on where they are and who their victim was. So we would assume, probably due to stigma, that sexual offenders who offended against children are at greatest risk. But that's only true in that pretrial, arrest, jail, awaiting sentence phase. Their risk actually goes down once they're incarcerated long term. And there seems to be some effective policies in place to protect them. In many jurisdictions and states, sex offenders against children are housed in separate facilities from other offenders. They tend to be monitored a lot more because of this stigma and risk. And it's not just for suicide, but risk of being attacked by other prisoners who may find out about their offenses, or who may just suppose that's what their offense is. And so that's risky for them. But in general populations of incarcerated persons, men who have sexually assaulted adults or committed rape are actually at higher risk of suicide than are people who offended against children. And then we see that reverse effect where pretrial and that jail phase where they're awaiting or they're being questioned, the offenders against adults are less risky than offenders against children. So it just kind of switches at some point. There's a growing body of research talking about their relationship with custodial officers, showing that the better the officers know them, and most importantly, whether or not those officers know that they have a mental illness. And that seems to have some effect on early detection of suicidality and their willingness to tell someone that they're having these thoughts or engaging in self-harm behaviors. And so what they found is that the less officers know about inmates or forensic patients, then the greater the risk is for suicide and self-harm. And then also recent adverse events. This is true of people who are not offenders, but in particularly with offenders, there are certain recent adverse events that tend to be more significant. Death of a family member, particularly if they aren't able to go to the funeral, talk to other members of the family, if they're not given a lot of information about what happened, if they have some sense of guilt about being in prison and this person dying, like if a parent dies and they feel that they've somehow betrayed them because they didn't get out of prison. These types of things are identified in the research as specific adverse events that can predispose someone to making a suicide attempt, self-harming, or dying by suicide. Other ones include, and again, this is true in general population, but magnified here, significant medical diagnosis. And so when I worked in a state prison in Arizona, I worked on the terminally ill unit and the medical unit. And it was just well known when someone was diagnosed with cancer, they're going to be on suicide watch for about a week, because many times they didn't want to go through what's involved in either dying by cancer or being treated for cancer in prison. And so they felt like, well, it's again this idea of I choose how I go. So certain recent adverse events have been identified as greater risks than others. Oh, death of a child. I said death of a parent, death of a child is the other one as well. Now, this is the one people don't like to talk about, and the U.S. has not done a lot of research in this area, but the UN has commissioned a number of studies to look at internationally what are systemic factors that contribute to those suicide rates we talked about earlier that are so high in a lot of other countries. The first kind of low-hanging fruit that they look at is prison overcrowding. You know, does the degree to which people are overcrowded and their overcensus affect suicide? And the answer is kind of, well, yes and no. So to some extent, prison overcrowding can exacerbate suicidality. It just generally places more stress on the people in the system. You get more violent people in close proximity. It does not go well. But it does have a protective effect in some facilities, because when they get over census, they start taking a room that's a single cell and they make it a double cell. And what they found is that having a cellmate or roommate in a forensic facility or correctional facility actually lowers the risk of serious self-harm or suicide. And that's largely because another person's watching and they're able to maybe alert somebody and tell them that something's not okay. Now, prison bullying and violence, the rates of violence within an institution, whether it be a prison or hospital, are significantly related to the rates of suicide attempts and deaths by suicide and self-harm behaviors within that institution. Two that are kind of related, but frequent prison movement or relocation specific to that person. So if that person is relocated quite frequently to different cells, different rooms, different prisons, different wards, that increases their risk of suicide. There's some speculation that that has to do with lowering their social support because they're being moved to where they may not know anybody else. And it also has to do with that previous fact of the better the staff know you and know about your mental health needs, the less likely you are to engage in serious self-harm or suicidal behavior. So if you imagine somebody moving again and again and again, staff aren't going to be familiar with them, and they're not going to be familiar enough that that person trusts them to go up and say, hey, I'm not doing well. But another related factor is high prison population turnover. So if you have a transitory sort of unit, if there's this feel of people coming in and out all the time, that also creates a greater deal of stress on the system. And people within that system who are vulnerable to suicide and self-harm become more so. Now this one probably won't surprise anyone, but negative interactions with custodial staff. So negative interactions with correctional officers, negative interactions with frontline forensic inpatient staff, those do increase risks. And so, you know, when you do training with staff, for example, they're like, oh, you want me to be nicer to them? Yes, I do, right? Because it could have some pretty significant impacts on people. Another one, low staff engagement. How much are the staff committed to their jobs? How much are they committed to working with this population? How much do they like where they're at? You know, are staff frequently requesting transfers? Are staff complaining audibly about the level of violence? Or in my realm of the world, I always hear, I don't want to work with a bunch of child molesters. Like, okay, go say that where they can't hear you, because they're not all child molesters. You know, and it seems flippant of me to say that, but just the number of times that clients will recognize very readily who does and doesn't like them and who does and does not like their job does matter in terms of safety. Again, we have stigma as a systemic factor, and this is stigma broader than, or more, well, there's the broad stigma of this person's an offender or this person committed a specific type of offense, but then there's the kind of local specific stigma of which ward or unit or building you're in. You know, oh, this is the worst ward in the hospital, or this is the most violent building in the prison. That has an effect as well. Makes people feel like others don't want to work with them, others don't trust them or like them, and they're less likely to tell them what's going on. Another systemic factor that I already mentioned, but is just that lack of mental health resources, particularly for assessment and intervention and successful and effective medication management. And so, as an example, like I said, I worked in a prison in Tucson that had 5,000 inmates, 5 units, 1,000 people per unit, 2 psychiatrists for the entire facility. One of them was dedicated to 2 units in particular because he was fluent in Spanish. And those 2 units were Mexican nationals, and so you could not work there unless you were fluent in Spanish. And we were considered the mental health prison for the state. So anyone who was on a psychotropic med or who had a psychiatric diagnosis got sent to Tucson. So if you think about that other psychiatrist who has 3,000 people and the terminally ill unit, right? 3,000 people, the nursing home unit, the terminally ill unit, and the suicide watch unit for the state. That's just not sufficient. One person can't do that, not not the way that they would probably want it to be done. And so I would like to say that that's not common, but it is, especially when we're looking at privatized prisons, which is kind of a new movement in the last 20 years or so, because oftentimes privatized prisons won't even hire mental health staff. They contract out, and they'll have somebody who comes on a given day of the week. And so it's not someone who has daily contact with the clients that they're intending to serve. We also see, in terms of lack of mental health resources, and that's, looking at assessment, that's, we talked about that, but also intervention is largely group-based therapy. It's very rare to get individual therapy in a lot of these really large institutions just because of allocation of resources. And then also when we look at systemic factors, just barriers to effective reentry. So some of the research that I've been doing in this region is looking at rural reentry practices, and what does that look like from the perspective of mental health treatment providers who provide court-ordered treatment, and then also probation and parole officers who kind of serve as the case managers, the frontline case managers and supervision agents for offenders in our local region. And universally, they come up with the very same things. We need more inpatient beds, we need more substance abuse treatment, we need shorter waiting lists to get in for care. People don't have basic needs. They're not concerned about their treatment when they don't have food, right? Or they don't have transportation to get to treatment. It's really hard to get them there consistently when they're reliant on a family member or a neighbor who is driving them all the time because their license has been suspended or they can't afford a vehicle. So these things are common in our area, but they're common nationwide, they're common worldwide in terms of effective reentry practices, and particularly with regard to looking at people who are at high risk for hurting themselves. Now, there are some differential risk factors for suicide and self-harm, probably not surprisingly. Depression, anger and aggression, and a clearer intent to die are more commonly linked with suicidality as opposed to self-harm. It's not to say that someone with depression won't hurt themselves, but more often with kind of chronic self-harm behavior, we see more of that emotional instability and volatility, borderline personality disorder diagnoses, antisocial personality disorder diagnoses, and then sexual trauma being far more prevalent in that population. So we do see a little bit of differential risk. Now, in terms of risk factors post-release, death by suicide is 8 times higher for men and 36 times higher for women post-release from a jail or prison. It's 156 per 100,000 released prisoners, and that's a really high rate. If you think about it, it's 23 in custody in state and federal prisons, 43 per 100,000 in jails, and then it jumps up to 156, which is more than 3 times the jail rate, after they get released. So people who've just been released are at very, very high risk. If you look at forensic psychiatric patients who have a greater degree of psychopathology and usually a lot more complex system of needs, the risk for suicide post-release is 50 times greater. And so often resources are allocated differently for these populations, and they follow psychiatric patients a lot more closely. Some of that's also stigma and covering yourself, right? Nobody wants to release that not guilty by reason of insanity patient and have them go out and do something. But it's also very well known that they're at high risk of suicide once they're not being monitored as closely. Now, specific risk factors. The greatest risk period for people who've just been released is within 28 days of them having been released from a facility. And so that first month is really critical, and that's where you see a really high degree of deaths by suicide, serious suicide attempts, self-harm behaviors necessitating medical intervention, hospitalization, return to care. You'll see people psychiatrically hospitalized within that first month post-release. Other things that are similar, previous suicide attempts, psychotic spectrum or substance-related disorders. Criminal recidivism and reincarceration, though, is a risk factor, too. So when we think about the rate of suicidal ideation and suicide attempts and death by suicide and whatnot in jails, some of that is also driven by this. If someone gets released and they commit another crime and get arrested, they're at a very high degree of risk for some kind of self-harming or suicide behavior. It's theorized because they know what they're going back to. and they probably also know they're going to get a longer sentence this time. They may lose other privileges that they had worked really hard to gain back. So that's a pretty significant risk. Now, availability and use of illicit substances, particularly alcohol, is another risk factor that, again, we don't see this as much in custodial offenders because they don't have as much access to it. I won't say they don't have any, because they do. There are drugs in prisons and jails. But they have more ready access in the community. And if you think about some of the environments that these folks will return to, they're going to return to environments with family members who are also abusing alcohol and other substances and who may make it available to them. And again, it's that disinhibiting effect. So that even though they may not in sober moments want to hurt themselves, they're still not great, they're unhappy that they've just gotten out of prison, maybe they're struggling to find a job, and then they get really intoxicated and that suicidal ideation can spike and lead them to engage in some kind of harmful behavior. Again, that lack of social support, even after they've gotten out, they still don't usually have a readily available social support network. There's not people clamoring at the gates of prisons to bring offenders into their homes and help them or be friends with them. And in fact, a lot of our policies that we've put in place, particularly with regard to sex offenders, decrease that social support really dramatically. You know, if you have to put a sign in your yard, if you have to notify people that you're a sex offender, people don't necessarily want to invite you to the neighborhood social or talk to you when you're getting your mail. And so there is that lack of community support, but also often lack of family support as well after they've gotten out, because what they have found is that consistently people report feeling very depressed and suicidal because their families have moved on without them. And so they've been incarcerated and they get out and everybody's kind of moved on with life and they're not a part of it. And so even though the family may be there and say they're supportive, they don't feel that level of support because they're seeing that you don't need me. You know, I'm just a burden. And then in terms of age, older offenders are at greater risk when they're released. And to some extent, this is largely because maybe the older men are increasingly at risk for suicide in the U.S., but they also have related that to the length of incarceration as well. And so they're older when they get out, they've been in for a really long time, and they don't know how to function as well. I worked in the prison. I did a pre-release group with one of the social workers, and at the time, you know, talking to people who've been incarcerated since before I was born. And so they'd never had a credit card. They didn't know, you know, how to navigate the systems on the phone where it says press 1 to do this. They'd never had any of that. And so getting out, they felt really, really helpless because they did not know how to function in today's society as effectively. And so we see that kind of mirroring in these populations as they get out. Now, in terms of targets of prevention, so some of these are just general for any offender at any phase. Mental health screening and intervention practices need to be improved. I think everybody who works with offenders and who does mental health, whether with community offenders or offenders in some kind of custodial secure care, recognize, you know, we need more. We constantly need more people. And these are often, you know, people say, well, why don't we have more? Some of it is because it's, you know, people don't want to go work with violent offenders, right? People don't want to go work in a facility where they know there's a high probability they might be assaulted. Federal prisons pay well, but state prisons and state hospitals do not pay well. And so there's also a recruitment issue. Even if you have the positions, sometimes it's hard to find people who are willing to fill them. Another factor related to recruitment and retention is, you know, they build prisons and maximum security psychiatric hospitals out in the middle of nowhere because people don't usually want them right in the middle of their community. And so there's not a huge base from which to select mental health providers, and it's hard to encourage people to move to a town of like 10,000 where half of that's the local prison population and the rest of them are staff. And so, you know, it's not just the fact that we don't always have the funding in offender work, but that there are these other sort of systemic barriers to getting the care that people need. That resource availability, again, is really important. And a lot of State hospitals and state prisons have now started trying to get themselves declared for student loan repayment so that they can recruit mental health professionals, they can recruit social workers, psychologists, psychiatrists, occupational therapists. We need greater psychiatric support, I mentioned that. We need better risk prediction. These factors that I've mentioned, you know, some of them have been really, really well researched. Others of them less so. Others of them are less attractive for systems to research because they don't want to acknowledge that they might be contributing to some of it. We all know if you're overpopulated or over census that there are problems, but there may not be anything they can do about it. And so it's not one of those factors that people really want to delve into because they say, well, there's nothing we can do. But most of our risk prediction for suicide and self-harm focuses entirely on those individual factors. And working in a facility where maybe there's a disproportionate number of people with those risk factors. I mean, if you're working on a ward where everybody has a history of prior suicide attempts and self-harm, we need to have a better way of differentiating who we probably need to watch the closest. And then also just improving those relationships and points of human contact, because a lot of the way that we have built offender systems and staffed offender systems is with the idea that they're the bad guys, we're the good guys, don't talk to the bad guys. And the fact of the matter is, if you see them on a day-to-day basis, these are people, and consistently treating them in a harsh and punitive manner does not improve their mental health. And so more recent shifts in paradigms have shown that, I don't want to say prisons are becoming kinder, gentler places, but there's this greater acknowledgement that going in and being overtly confrontational and just assuming they're lying to you is not actually an effective practice for rehabilitation. And so we do see kind of a shift in how people are being trained, both frontline staff and then professional staff as well. Now, in terms of prevention and custodial settings, there's this difference between identifying risk versus managing risk that is often, this distinction is lost. They're really concerned with identifying risk, but not so much what to do when someone's at risk. The sort of frontline response is to put them in a suicide watch cell. And I say this, and I mean no disrespect, but in Arizona it was called the Naked Bologna Sandwich Watch. Because they took away your clothes, because people had tried to hang themselves with their clothes, and all you got to eat was a bologna sandwich and 5 sheets of toilet paper at a time, because yes, you can make a noose out of toilet paper, I discovered. That's not therapeutic. I mean, that's just not. You're in a cell without any clothes, there's cameras on you at all times, nobody really talks to you. And so managing risk is an area that they just don't do very, very well in a lot of correctional institutions. Another important prevention area is quite simple, just limiting access to means. Now I say we took people's clothes away, and I didn't do it, I was there, but you know, they took people's clothes away from them. But the most common method of death in custody is by ligature or hanging. And so reducing ligature points, if you ever get to see this, they have a lot of really new ways of designing and building facilities to mitigate suicide risk where there's simply nothing for you to tie a ligature to. You know, they remove all the shower curtain rods and toilet paper holders and things that someone could conceivably tie something to. And so it's limiting access to means by not taking away their clothes necessarily, but just trying to reduce that overall risk, trying to remove sharps, using flexible pens, things like that. The research, though, from the UN, I mentioned they had done kind of a large-scale study of what puts people at risk. One of the things that was at risk related to overcrowding was spending all of your time alone in your cell. And so simply letting people out more and getting them more engaged in activities within the prison, as much as one could safely do, does actually reduce suicide risk and self-harm. Training and support for staff, and relatedly anti-bullying interventions and teaching staff how to intervene when they see something going on that seems to be a problem among the inmates or prisoners. Another suggestion is creating what's called a first night center. Now this has been less focused on for psychiatric facilities because they tend to watch people more closely and the first few days of admission anyway. But within prisons and jails, this idea of having a special unit for people who it's their very first time being incarcerated and who may have lengthier sentences, and it's called a first night center, but it's expected to extend for maybe a week or two, so that they're in there with other people who are also new to prison environments. And this idea that they then may be less vulnerable to bullying by other inmates who are trying to scare them, and also having more staff on hand to allay fears they have about first-time incarceration. And then also this movement toward trauma-informed corrections, and just recognizing that people come into these custodial facilities or hospitals with a pretty substantial history of trauma, and that not recognizing that and not acknowledging that can actually exacerbate existing symptoms of mental illness or other trauma-related problems. And so just the idea of trying to be more sensitive to that can reduce suicide risk, particularly during that first period, initial period of incarceration. Now, in terms of community, training and support for community supervision agents, training them in what to look for. In my own research, what we found is that overwhelmingly the probation officers we talked to said, I've never had any mental health training. Some of them took intro psych as they were getting their degree, or maybe had abnormal psychology, but they didn't feel equipped to work with their clients' mental health needs. Now, they acknowledge, like, I'm not going to do therapy. I know I'm not supposed to do that, but I don't even know what to say to them when they tell me these things are going on. All I can say is, you probably should talk to your therapist, right? But they may not have an appointment with that therapist for another 2 weeks. The probation officers expressed universally they felt pretty helpless. And so offering more support in just even screening for suicide and self-harm, and how to talk to people about the problems they're experiencing post-release. Greater clinical monitoring in the first 4 weeks post-release, so not just that one, like, okay, you met with your probation officer on Monday, great, you're going to see him next Monday, go to work. You know, this idea that we devote more clinical time to people in that first 4-week period, and particularly those with prior suicidality and substance abuse problems, because you can still triage it. It doesn't have to be absolutely everybody in their first 4 weeks, but we know those folks are at greater risk. Evidence-based transition programming. So we don't have a lot of evidence-based transition programming. We usually have some aftercare plan that looks pretty generic for a lot of people. So we don't have a great deal of individualization within the system. I used to hear complaints from people like, everybody has to go to substance abuse treatment, everybody has to go to anger management, and that may not be something that's of benefit to them. And then specific aftercare resources for those who are at greatest risk. And so we do know some of the risk factors, and so how do we intervene with those folks? Also looking at family reunification efforts, and how do we teach this family to be supportive, and how do we teach this person to kind of fit back into their family? For the most part, family reunification efforts for male offenders, there's not a lot out there. For female offenders, they do spend a little bit more time on like parenting instruction and parenting classes, but it ignores some of those other factors that may still be relevant, like them feeling like an outsider in their own family, or feeling like they betrayed their family and now they're back. And then also greater interagency coordination and integrated team-based care, because you see a lot of siloing when you look at corrections. We spend a lot of time talking about integrated healthcare and how great integrated interprofessional teams are, but you don't see that mirrored in the criminal justice world or the community supervision world. You usually have some kind of supervision agent like a probation or parole officer. You have mental health agents who are contracted and who answer to the court or who may answer to probation, but because of a lot of the rules of confidentiality, there are things they can't say. And because of that lack of training, the community supervision agents may not know what to tell them that's relevant. And so we see a great degree of disconnect within community care for recently released offenders or offenders on supervision. All right, so any questions? Yes?
You mentioned that suicide was the leading cause of death in U.S. prisons and HIV was second. So I was wondering if you know anything about the interaction between the two. I could definitely imagine a synergistic effect, especially if the diagnosis of HIV was made in prison or recently prior to incarceration. And another important point of relevance to suicide risk is with suicide risk going up post-release, HIV risk also goes up post-release.
Right. I haven't seen a lot on how those two may be related. I can say from having worked, I was on an HIV team in a prison. The prison systems actually do have fairly good integrated care for HIV management. They get more services. So I don't know if that would mitigate potential suicide risk because there's more points of contact for them with mental health and medical professionals. But I haven't seen a lot of information looking at the rates. It hasn't been identified as a risk factor within this literature, but I haven't looked at seeing whether or not there's a correlation.
Yeah, I think there might be increased access to primary medical management. But I'm not sure that would extend to mental health.
No, that's true. Although in a prison environment, they're so impoverished with regard to any kind of human access that even a person in another discipline can make a huge degree of difference. Because otherwise if you've got somebody who's in solitary confinement, they don't talk to anybody. Yeah. Okay. Other questions? Yes?
Given the fact that we still have a problem with those people that they have diagnosis of the transgender and they being incarcerated in their birth
Right.
gender, did we have any kind of information about how much of the suicide risk goes up for those people?
I don't know that. I haven't seen anything on that other than from the context of looking at it with regard to mental health problems. Because often what happens with a person who's transgendered, and I've had several clients where this was the case, where they were born male, they had been living female for a number of years, and then they're put in a male prison. They usually end up in protective custody or protective segregation. And for some, that can exacerbate just depression and anxiety and feelings of hopelessness because they aren't able to have human contact to the degree that they might want.
And also, you mentioned the numbers in Norway being 180
Per 100,000, yeah.
I think the numbers of the total number of the prisoners that we have in the United States makes a difference also. And it's lower, it's 23 out of 100,000, but the total numbers of the death as a suicide in the U.S. is way higher than the Norway.
Yes, it is. It is. We have a much larger prison population. It's just shocking to see, though, with Norway and Sweden because at least in sort of corrections and criminal justice, we're always told that they have such a better system than we do. That their system is far more rehabilitation focused and that we should look to them, and then you see these rates of suicide that are much higher. So I think they're probably dealing with a higher acuity issue. We have more people incarcerated by far, but those that they have incarcerated are a higher degree of acuity and risk for a number of things like violence and suicide. So I think there's an interaction there. Other questions? No. All right. Well, thank you very much, and thanks for coming.